Hello? Okay. All right. Thanks, everybody. All right, Devin, that was awesome. Thank you so much. All right, next up is Dr. Daniel Mbom. He's a PGY2 at Tampa General Hospital in the emergency department, and he is our hype man. All right, this is taking him a lot of energy to sit in this chair and present to you. I'm just going to let you know right now. A couple interesting things about him is he's from Nigeria. He went to the Medical College of Georgia in Augusta. He loves to eat, and he makes the meanest chicken wings.
Spicy, very hot,
Spicy.
very hot. It's
Do you,
only good when it's hot.
do you bread them?
Huh?
Do you,
No, no, no,
no
no,
bread.
no, no.
Okay,
It
no,
has
no.
to be naked.
Okay, and blue cheese or ranch?
Oh no, no, no,
Oh,
no,
none of
no.
that.
Yeah,
Okay,
you have
never
to
mind.
take the spice the way it is.
Okay,
It's like-
okay. He likes it naked. Okay, all right, very good. Okay, without further ado, Dr. Daniel Mbom.
Hey y'all. Today we're gonna be going a little bit over ocular ultrasound. I like it because it's easily accessible. You throw the probe, and for the most part, you see what you need to see. So without further ado, let's get this party started. You guys already know about the anatomy of the eye, so I'm not really gonna spend a lot of time on this slide. But all we just need to do is know there's an anterior chamber, know there's a posterior chamber, and within each, we're gonna be able to see the things that we need to see, all right? So it all always boils down to which probe do you use to get the imaging that you need to see. We're looking for a readily accessible structure, looking for a structure where we need to see intimate detail, so we need to use a probe that's going to allow us to see that. So guys, which probe do you think we'll use among these three to visualize the eye? Linear, yes, that is it. So this is just a small chart for the most part that explains why we use different probes. It doesn't really go into great detail, but it just gives you a quick overview of when to use each probe. But like you said, we're using the linear for 2 or 3 main things. One, it has high frequency. Fancy way of saying it allows you to visualize structure with great clarity, really good resolution, okay? And you want to use the ocular preset. It adjusts the energy levels. It actually brings the object into focus more. So you have less manipulating to do on the ultrasound machine. That being said, you throw the ultrasound probe on the eye. Is that typically how you start, or do you need to start with patient positioning and other things? So to make your exam more easy, you always want to start with patient positioning and machine positioning. And we're just sort of going to go down the slide to see all the things that we need to do. I'm not really going to spend a lot of time on this because we're going to go over them in the subsequent slides. But once you throw the ultrasound probe on the eye, you'll be able to visualize all the structures listed above. All right, so we got our patient. We lay them down. You want to make sure they're nice, flat, or supine, or maybe at a 30 to 45 degree angle, depending on the patient comfort. You want the machine to be nice, close, easily accessible to you. That's done. Next, you want to apply gel. When in doubt, just throw some more gel on it. The more gel, the better. So there are 2 different ways of doing this. One class is throw a tegaderm on it, make the patient more comfortable, because sometimes if the patient opens their eyes mistakenly during the exam, the gel in the eye gets a little bit uncomfortable, and then the patient starts cursing. You don't want that. However, a case happened the other day that made me rethink my tegaderm policy. I was scanning with Dr. Hansen, and she asked the patient, do you by any chance have fake eyelashes? I was like, whoa, I never really considered that. Apparently, fake eyelashes cost like 150 bucks. If you put tegaderm and then pull that off, patient gets even more upset. So these are really important questions to ask before you start, deciding whether or not you're going to use tegaderm on the eye. That being said, the most important step is anchoring. As you're scanning through the patient, you want to be able to turn around, press buttons on the ultrasound machines to freeze, get good images and things of that nature. For you to be able to do that, you want to make sure you don't apply tons of pressure to the eye. And to accurately get that, you want to make sure you anchor. So the images on the right versus the left, you don't necessarily have to use those. Those are just typical examples of what some people do. As long as your anchoring technique is good and you're not applying pressure to the eye, you can get a pretty good image. Then the gentle pressure pretty much goes hand in hand with what we talked about. If you look at the image on the right versus the image on the left, on the image on the left, you see that there's a little bit more pressure applied to the eye, and that's why it's more horizontal versus a nice, more elliptical image that you see on the right. So that's more pressure versus less pressure. Just things to look at when you're doing your ultrasound. And we'll always get to probe marker placement. So you always want the probe marker to the patient's right for transverse when you're doing an ocular ultrasound versus towards the head when you're doing a long ultrasound. Lastly, you want to make the patient work a little. All right, we all know about our fanning technique. We all know about our rocking technique, and you're definitely going to use that during the ultrasound. But making the patient move their eyes in different directions also helps you assess extraocular muscles and helps things move in the eye for you to be able to see what you need to see. So lastly, we're going to start with a couple of cases. So we have Mr. JJ. He comes in. He tells you that he has some sudden onset vision loss that's painless. That happened a couple of hours ago. So he came in. He used a buzzword. I felt like a curtain just dropped over my vision. What do you think is going on after putting the ultrasound on his eyes? What do you see? Yes. So I like going over things over and over because it sort of helps me. Repetition helps me understand. How you differentiate retinal detachment from a lot of other things is you look for that wonderful optic nerve right behind. So you see a wonderful, thick, hyperechoic line that sort of attaches to the optic nerve. In this case, the sonographer is using the fanning technique, going back and forth. So you can also combine that with having the patient look left and right to let you see that it is following the optic nerve as it's going. This is another example of that. Initially, the patient's eye twitches, and you can see that it is following the optic nerve. And then the ultrasonographer uses the fanning technique. You can also see some floaters going around. So this is another case of retinal detachment. As you can see again, it's wonderfully attached. It's nice and thick, and it's attached to that optic nerve. This patient is really moving their eyes left and right here. But again, same principle. So people don't always read the textbook. There can be multiple things going on with patients. Okay, you can have two similar things going on, and this is a case of both retinal detachment and some hemorrhage going on. So we have another case where Mr. RR comes to the ED, same story, curtain vision. You put the ultrasound probe on his eyes. What do you guys see? Sorry? Yes. And do you guys see by any chance this really thin line there? Kind of looks like a retinal detachment. It's a vitreous detachment. So retinal detachment and vitreous detachment, for the most part, look alike. The only difference is it does not attach to the optic nerve. So here you see the optic nerve going in and out of focus, but there's a nice hyperechoic line. It's not as thick as the retina, so it's really nice and flimsy, but it does not attach. That's the main difference. Presentation is going to be the same. In terms of retinal detachment versus vitreous detachment, there could be visual cuts, there could be complete visual loss. It's always going to be painless for the most part. It could be traumatic or atraumatic, but the story is going to be the same. So how you differentiate it on ultrasound is thick versus thin line. Does it attach to the optic nerve or not? So these are some other cases of, again, it's not attaching to the optic nerve. It's a nice hyperechoic line, but not as thick as the retinal detachment. And now we have Miss JJ who comes in. She's telling you that she's seeing weird stuff in her visual fields. So you throw the ultrasound probe. What do you guys see? I think I see a little something in her eye, and it seems to be swirling. So whenever you guys see that washing machine-like effect, it is vitreous hemorrhage. It's going to just swirl, almost like a cycle in the washing machine. You just see it go back and forth and back and forth. I remember one time the patient was asking me, hey, what's going on? Apparently I spent too long looking at the eyes because I was mesmerized with the swirling going back and forth, and I forgot I was actually doing a visual exam. So it can be quite interesting to look at. So one of the reasons why you want to have the patient do the work is also, if you're just fanning through the eye, you'll be like, okay, I see stuff. Maybe that's bleeding. I don't really know what that is. But if you have the patient move, you see that swirling effect that's pathognomonic for vitreous hemorrhage. Now, vitreous hemorrhage has a mimic that almost looks exactly like it, but the only difference is they're really bright hyperechoic spots, which are calcium deposits in the eye. So they look exactly the same. It has the same washing machine-like effect, but they're more due to calcium deposits. So if you just see stuff that looks like a starry sky with a washing machine-like effect, it's actually not vitreous hemorrhage. It's calcium deposits in the eye. This is another case of vitreous hemorrhage, the wonderful swirly effect. Same here. And in this case, there are two things going on. We have both a vitreous detachment with that thin hyperechoic line, and we also have the washing machine effect of the vitreous hemorrhage going on. All right, so we have Mr. RR who comes in. He's told you he's had some eye surgery in the past, doesn't really know when, but he's telling you that he has some visual field deficits. You scan through his eye. Is there anything that sort of points out to you? Exactly. That lens is a bit shaky. This is another example of fanning through the eye with lens subluxation. And this is another example of fanning through the eye with lens subluxation. Again, I don't know whether you guys have already noticed. With fanning, you can see stationary objects, but if you have the patient move the eye, you see the objects also move. So more dynamic versus stationary. Okay, JJ is a lady with an elevated BMI who's coming in, who has a headache and decreased vision for the past couple of months. You scan through her eye. Is there anything that stands out to you guys? Maybe at the bottom here, I see maybe an elevation. Exactly. A wonderful case of increased ICP. Okay, so when we talk about ICP, we have to differentiate increased ICP, which papilledema is a surrogate for, from more chronic with papilledema versus more acute. If it's more acute, you would not see that elevated optic nerve head, versus if it's more acute, we use a different measurement, which we're going to talk about on the other slide. But I'll get to it on the other slide. All right, so optic nerve dyselevation. There are different studies that have been done, and some of the studies are contradictory. In this study, only a small sample were used of 40 kids. However, this study compared to other studies that have measured elevated optic disc have noted that any value above 0.6 millimeters is more suggestive of increased ICP. Studies comparing optic disc elevation were contrasted with studies that compare the measurement of elevated diameter of an optic nerve sheet, and they're contradictory studies. Some say optic disc elevation is more sensitive. Some say the diameter is more sensitive. What I say is use both of them and your sensitivity dramatically increases. Both of them have a greater than 90% specificity and sensitivity, but just use both. If you're just thinking ICP, you're going to measure the optic nerve sheet diameter. If you see evidence of papilledema, measure it and also measure the optic nerve sheet diameter. And at the end of the day, both of them will give you a chance of hopefully having increased accuracy of diagnosing increased ICP. So in the case of papilledema that we do see that elevation. If you measure it, it will be above 0.6 millimeters. And if you also measure the optic nerve sheet diameter, and you're not measuring the optic nerve itself, you're measuring from outer border to outer border. So it will be from around here to diagnose papilledema in this case. So what we just talked about was measuring the optic nerve sheet diameter. You want to move 3 millimeters back, and you want to measure across. If it's greater than 5 millimeters, it's more indicative of ICP. However, there's between 5 and 6 millimeters, which is an unknown zone. Some people, it could just be normal for them. So the number I actually want you to remember is 6 millimeters, not 5 millimeters. If it's between 5 and 6, it's, what do I really do with this? Do they really have increased ICP, or is that a normal for them? Different studies have shown that between 5 and 6 could still be normal for some people. So just remember the number greater than 6. So you're measuring back 3, you're measuring across. If it's greater than 5, that's good. But greater than 6, it's even more sensitive and specific for increased ICP. So this is just a chart saying the difference between papilledema, elevated ICP, and pseudopapilledema. Acute versus chronic versus what is this? So for that, we're going to give a case where we scanned an eye and we're seeing an elevation. The optic nerve sheet diameter kind of looks more dilated, but we'll measure it in a sec. So what do you guys see? What do you guys think is going on? Exactly. So in this case, the difference between this and the previous one was, if you look right here, this elevation, it almost seems like there's a hyperechoic center. So that's a mimic. It's called optic nerve drusen. It's normal for some people. It's just a calcification. So if you measured, this will be greater than the 0.6 millimeters, which makes you think, okay, I saw a bump, I saw an elevation. This sounds like papilledema. I haven't measured yet. It sort of looks elevated. But if you see that the center is hyperechoic compared to the previous here, that is more isoechoic, or the same with the optic nerve sheet. That's what you're looking for. So it almost looks like a stone on a renal ultrasound, that same hyperechoic texture. So that's optic nerve drusen. And if you measured, it'll be normal. Less than 6 or less than 5, depending on which measurement you're using. So a guy comes in, he's had some altercation at a bar or some other place. His eye's swollen shut. You don't really know what's going on. You throw the ultrasound probe on his eye, and this is what you see. What you guys thinking? Exactly. I don't know what that is either. So if that ever happens to you, I want you to think of globe rupture. With globe rupture, you just go, what is that? That doesn't look like the picture of the eye that I was taught to look for. So the thing is, again, the eye is swollen shut, right? So it's not someone who comes in where you obviously see that there's penetrating injury to the eye or the positive Seidel sign or things of that nature. You don't know what's going on because the eye is swollen shut. Once you put that on, you're like, okay, globe rupture, I'm calling up though. This is a case of emergency. Yes. 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 So there's actually another technique. The other technique is not putting it directly on the eye. You can actually use the bone on the side where you're not applying increased intraocular pressure and you'll still be able to visualize the orbital structure. So as long as the contraindication is pressure to the eye. So if you can achieve that just by doing this, then you still get the same effect without applying pressure. Yes. And you can still do it in 2 views, but you're using the bone to sort of protect and decrease application of pressure to the eye. So globe rupture can look nice and wonderful where you could still see the structures of the eye itself and just a ton of stuff in the eye that's not supposed to be there. It could be the previous picture where it sort of looks like mush. It could be an example like this where you see the eye sort of compacted. So it can look different depending on what exactly is going on with the patient versus a normal eye. So this is a guy who came in. He said he had sudden onset vision loss that started over the past 24 to 48 hours. It was acute, it was painless, and he wanted to figure out what's going on. You did an ultrasound scan of his eye, and this is what you saw. What are you guys thinking? Okay, hemorrhage. Okay, it could be that too. But again, in scanning through the eye, this looks pretty homogeneous, right? It almost looks like a consolidation. Like to me, the story doesn't fit, right? You have this huge thing in your eye that supposedly took some time. And you said there was no trauma, nothing acute that could have caused this. It looks nice, it looks compact, and it looks homogeneous. This dude had an ocular mass that had been growing for a while. So his story did not match what he typically said. Opto was still called and all that, and they pretty much said the same thing. They're like, this guy has had decreased vision for a while. This is not something that just started. So like you're still using your clinical judgment when a patient is telling you something with what you see on ultrasound and trying to put the pictures together. That being said, this is a wonderful pocket card I saw. It has some of the things we've talked about, has some of the things we did not talk about. So again, retinal detachment is attaching right to the optic nerve. Vitreous detachment is not attaching to the optic nerve. Then we have our wonderful washing machine sign. Those are the 3 main things that we talked about that I want you guys to look for. And whenever you see optic nerve elevation, I want you to think, do you see any hyperechoic center that could represent calcification? And then go back 3 from the optic nerve, optic disc, and measure across 5. If it's greater than 5, the bigger, the better, which increases the risk, the chance of ICP. And to go over a summary slide, gel, gel, more gel. If you don't see what you need to see, put some more gel on it, and you will. Next, turn that gain up. For the most part, you're going to see what you need to see. However, if you're still saying I'm missing something, after scanning normally, overgain, because it will show you things that would not come out normally. Also, make the patient work. Look left, look right, look up, look down. Consider the clinical picture. Does the story match what's actually going on? Phone a friend, all right? A lot of times we look at something, we don't really see what we're looking for. Just have somebody else look at that. Hey, are you seeing anything I'm not seeing? And at the end of the day, it doesn't really matter whether you know the diagnosis. Call Opto and explain your findings. This is what I see. I don't really know what it is. Can you guys come take a look at it? Or do they need to see you in clinic? That's all, folks. Do you guys have any questions? Yes.
Information on the optic nerve size for pediatric patients. What would that be at?
So they've done different studies, and in the studies, for the most part, it's the same as adults, plus or minus maybe zero 0.5 to 1 millimeter. So normal optic nerve size, diameter in kids is usually 4 millimeters and less. However, there have been some outliers that go up to 4.5 to 5. So they just say for consensus, both for kids and adults, just 5 or less is normal. And then for adults, between 5 and 6, gray zone, greater than 6, abnormal. Any other questions? Yeah.
Yeah, one more. I know we're not supposed to use like the colorimetric settings on the eye. Because it increases the temperature.
So you can, but you're using it for a short amount of time. So just like Devin talked about with that twinkle artifact, you can actually use the same thing when you see that optic nerve drusen. Other studies that have been shown is, so ultrasound is very operator dependent, right? You and I could both measure the optic nerve diameter and plus or minus maybe 1-2 millimeters, depending on what we're measuring. So some of the new studies have stated that if you actually put color flow, you're supposed to see blood flow on the borders lateral to the optic nerve sheath. It's not always the case. Sometimes you see it, sometimes you don't. So you just, I guess, to answer your question, yes, you can actually use color flow. You're not using it for a long period of time, so yes, you can. Yes. So I didn't show a video of it, but if you're worried about central retinal artery occlusion, right, and you put color flow right there at the optic disc, you'll actually see both the red and the blue flows. So in the case of central retinal artery occlusion, you will only see the blue flow, not the red flow. Any other questions? Thank you.
Yes, awesome. Thank you so much for your presentation.
Thank you.